Hi, everybody. So this is just a short presentation. I've actually been trying to present to the guys in the emergency department, but shame they've really been working hard and it's been extremely busy. And so we haven't had a chance to put time together to actually um, go through, an ECG, and hopefully we will in future. It's also my fault, I'm a bit late coming into work these days. So what I decided to do was let me rather just go through this ECG quickly, because it's quite an interesting one that I received from a local GP a few days ago. And so it's a real patient, came in to see the doctor. In fact, I think he's on this group, so I'm pretty sure he'll recognize the ECG as well. But it was a 37-year-old male patient who came in with a history of chest pain, central chest pain radiating to the left arm and left jaw as well, which was quite worrying. And then he did the ECG and he was quite worried. So he sent me a copy of the ECG and he just wanted some advice on what to do. So what we're going to do is that we're just going to have a quick look at it. It's not going to take us more than 5 minutes. And we're just going to try and see what we can figure out what's going on. So the first thing, as usual, when we start, we always look at the, sorry, I just want to get the right pointer on here. Okay, let's just try and, all right, there we go. All right, so here we have the, oh, sorry, didn't realize it does that. My apologies, it won't be as slow from now on. Okay, so here we look at leads 1 and AVF, and we can see that they're both pointing upwards. They're both positive deflections, so we know that it's a normal axis. This doesn't mean that everything's okay. It just means that we have a normal axis, and that's it. Now, when we start having a look at the P waves, we see the P waves are a bit flattened, but that may also be due to the orientation of the leads and how they are put. And if we go through one or two other areas, we see we've got some flattened P waves, and then we've got some normal P waves as well. But on the majority, they are a bit flattened, but within the normal range. The one thing of note is that there is quite a prolonged PR interval. And this prolonged PR interval gives you a first-degree heart block, which in and of itself is an incidental finding the majority of the time, but it means that the patient is at high risk of developing arrhythmias further on. And we can see that it remains quite constant, so it's not elongating or shortening or anything like that. It's relatively constant at around 6 small blocks. Then if we look at the rhythm, we've got narrow QRS complexes. We've got a QRS following every P. And then what we have as well is that we have the slight irregularity, which you can notice here, especially over these 4 beats. Now, these 4 beats in themselves cover about a few seconds. So this is what we call sinus arrhythmia. So this is the normal increase and decrease in your heart rate that's seen by breathing in and breathing out. So generally, when you breathe in, your heart rate goes up. You breathe out, your heart rate goes down. So this is what we are seeing over there. So it's not an abnormal finding, and it's something that you should actually, look out for. In fact, if your patient doesn't have it, that's something to be worried about. So that's where that irregularity comes from. And in terms of the rate, we look at the 2 narrowest normally when we work it out. So it goes somewhere like here, 3. So he is a bit tachycardic at just about 100 beats per minute. So you've got to think about what are the possibilities. So you've got a 37-year-old. The gentleman, the patient involved was a relatively good shape, not somebody who was, a smoker or anything like that, hadn't been ill recently or anything of that sort, and it just suddenly developed the pain. I did have, I think, a bit of social drinking, and when we say fit, we don't mean tremendously active, but not somebody who was completely sedentary as well. So he's not the best candidate for a myocardial infarction from a social point of view, but we have to remember hyperlipidemias, familial hyperlipidemias, and what you call it, muscle bridging, channelopathies. These are all things that can also cause it. So whenever you have a patient with chest pain, there's no harm in doing an ECG. So if we go through each and every area or every zone, if we look at the inferior zone, leads 2, 3, and AVF, what we see is that we do see an ST elevation. All right. So we're just going to keep that in mind. We do have an ST elevation. But what we also see is that our PR line. So from our P wave to our, well, what would be a little Q wave over there is slightly depressed, but not by much, but it is definitely a little bit down, but not by much. It's just barely there. So that's what we're seeing in these inferior leads. Then if we come to the right side of the heart, which is AVR, then we notice there's not much changes, not really anything of any great significance. We're going to come back to leads 1 and AVL in a second. Sorry about that. Okay, I'm not sure. It's just giving me some weird settings over there. Okay, so when we come to V1 and V2, the one thing we notice is what looks like a Q wave in V1. But remember, if you don't have a corresponding Q wave or pathological Q wave in V2, we're not really too worried about it. We do kind of expect this to happen, you know, in most ECGs. We do see a slightly high takeoff on the ST segment, but it's not terrible. And then if we come, so that's your septum that we're looking at. If we look at the anterior aspect, we do see a slight ST elevation also in V2. You can even see it in V1. In V3, it's not as prominent. It's more of a high takeoff. But if you were to, let's just annotate this. Let's try and draw a line over there. I think if it will allow me to do a line, I don't think so. All right, not allowing me to do a line. But if we had to go directly across, what is the electrically neutral line? If you look at it there, it's about half a block above. Here, if we come again, it's about a quarter block above. Here, if we come across, we can see it's almost in line, maybe about a quarter block above. But once we get to V5, V6, we can see that it jumps to about almost a complete small block above. In V1, in leads 1 and AVL, which are your high lateral leads, we don't see too many changes over there. It looks more or less normal. So we have to look at this and see what do we find. So we find ST elevations in leads 2, 3 AVF, so the inferior section, the anteroseptal section, so in V2, V3, V4, and we've also got on the lateral leads, even though not necessarily on the high lateral leads. So there's 3 possibilities when it comes to this. Number 1, you've got an acute pericarditis. You've got a widespread infarct because you've got no reciprocal changes anyway. You've got nothing to suggest that there's a reciprocal change. So you could have a very wide-ranging infarct. Or number 3, you could have a ventricular aneurysm. So these are the 3 most common reasons for having these widespread ST elevations. Direct cardiac trauma, there are a few other things. But just looking generally at this, this is what we would go at. Now, the one that you can already sort of take out is ventricular aneurysm. The reason for that is that we don't have any history of ischemia, we don't have any history of infarcts, history of trauma. You know, these are the types of things that patients should bring up or would bring up with you. You know, I was involved in an accident, I had a massive injury to my heart. They said there was damage, or, you know what, I've been for stenting a few times, things like that, you know. So basically, we don't have anything like that. So we did have a patient, another doctor who was on the group did send me one where we suspected a ventricular aneurysm in an 85-year-old with ST elevations and no reciprocal changes and severe central chest pain. So in that patient, we did suspect a ventricular aneurysm as well. And a ventricular aneurysm is exactly what it sounds like. It's an aneurysm of the ventricular wall. It bulges out, and it bulges out with each beat. And the problem with that is that it can rupture. If any of you are following the Twitter feed, X feed, you would have seen yesterday that I reposted a video of post-mortem of a heart involved in a ventricular rupture. And it was quite interesting to see where you can actually see the rupture and you can see the tamponade that took place. So that's quite interesting to see as well. So the other ones we said were, so widespread infarct, which is likely. We don't know. I mean, this patient could well have familial hyperlipidemia and, bridging problems, cardiac bridging problems, could have channelopathies. There's quite a few things that could be going on over here. I mean, beyond that, there's a lot of reasons for early infarcts, your lipid abnormalities, lipid metabolism disorders. There's so many of them that can lead to this. So, it's always a possibility and you never discount it. And then the third one that we have is pericarditis, which in a 37-year-old relatively well person is probably the one that you'd want to quickly try and rule out or rule in immediately. Now, in this case, we see a slight PR depression, although it's not as widespread everywhere else. There's just one here. So that made me lean more towards a pericarditis. Now, pericarditis, especially if it's viral, tends to have PR depressions, quite quite significant PR depressions, and in AVR you'll see a PR elevation as well. So in this case we don't see that. So this means that it could be a bacterial or inflammatory pericarditis. Tuberculosis pericarditis can also cause this, but at least it sort of it takes out viral. Our patient wasn't pyrexial, so the easiest way to rule out pericarditis: make the patient lean forward. If the pain is aggravated, does sound like pericarditis. And then when they lean back, if the pain is relieved because there's no pressure on the pericardium, it does, of course, lead you more towards the diagnosis of pericarditis. Now, I've always mentioned that, you listen for a pericardial rub. In 20 years of practice, I've never heard the pericardial rub. I'm sure some people have, but I've never heard it. If you have the ability to do an echo, you would do an echo. You'd look for pericardial thickening, things like that, fluid collections, so on and so forth, especially with tuberculosis. Pericarditis. So once you have pericarditis, the question becomes, okay, what are the dangers for me now? So the dangers, of course, are spreading of the inflammation and the infection, to involve the myocardium, endocardium, so on and so forth. But your real problem with a lot of these patients, and why they always need treatment, is that you could have then constrictive pericarditis thereafter. In other words, if there's a severe inflammatory response, there's a severe infective response, that scar tissue that forms on the pericardium, if not treated properly, could be quite extensive. And then what you have is a heart that's unable to expand properly. And once that happens, your heart compensates by becoming very overactive. You have a hypertrophic, overactive heart that's trying to pump out blood very fast because it's unable to expand properly. And this will lead your patient to having a lot of problems later on. So in this case, the patient did have pain on leaning forward, did have relief on leaning backwards. And even though, we couldn't say for sure it was pericarditis from this, that led us down the path of pericarditis. The patient was lucky enough to have a medical aid and did go through to the local private hospital where they were treated as well. And my understanding is that they had a relatively good outcome. He will have regular checkups with his physician. And that basically is it from there, from an emergency department point of view. What can you do in the emergency department? If you suspect an infective cause, antibiotics, steroids are of use sometimes, but not always. And in fact, it's analgesia that's probably the main thing that we try and give in the emergency department. The reason being, steroids, of course, can have other side effects, and, they do have cardiac effects as well. So, we're not trying to, let's say, get into the territory of the physician who's going to treat thereafter, because they need to develop a treatment plan and decide exactly what they're going to do for this pericarditis. But if you suspect bacterial, a shot of antibiotics is not going to cause any problems. We try and avoid pethidine in any type of cardiac illness. The reason being, it does decrease your right ventricular contractility. So you try and go for morphine. You wouldn't give, your TNTs and your aspirin in this case. You'll probably stick to morphine, paracetamols, things like that. Okay. All right. I hope that was okay. And hopefully tomorrow we'll post another one. I'm going to try and come in a bit early. It's my own fault that I haven't been able to do it in the department. And hopefully we'll have another talk on something else tomorrow. Okay. Keep well, everybody. Bye.